It is inflammation of the meninges manifest by cerebrospinal fluid pleocytosis. There are different kinds of meningitis, as you know, aseptic encephalitis or isolated meningitis or encephalitis or meningoencephalitis. So, beyond the neonatal period, what all CSF findings that we use? Basically, CSF is the most what we call diagnostic gold standard diagnostic for to differentiate what kind of a meningitis it could be. Okay, so we check for the white blood cells. Okay, we check for glucose, we check for protein, and we check for the appearance. See this chart, if you are completely getting inside your head, this will help you a lot for to differentiate what kind of meningitis it could be. So one is normal, one is bacterial, viral, and we can comment on it like how normal we see 0 to 5 lymphocytes. Okay, in viral we see 5 to 500, and in bacterial usually it is more than 1,000 PMNs. Okay, pleomorphic. Okay, and for the glucose, the normal CSF serum ratio is more than 2 by 3. In viral, it is normal, and in bacterial, it can be less than 1 by 2. Okay, and the protein it is mildly elevated in viral and is usually high in bacterial. Just keep in mind. And the appearance of for the bacterial CSF is always turbid and clear in normal and in viral. So, how you differentiate it? Usually, the PMNs are more bacterial, slightly 5 to 500 in viral, and you should remember the glucose and the protein levels for the same. Okay. So going on to the next slide, but first of all, the viral meningitis or what we call aseptic meningitis, it is very common. Okay, when it is usually seen, it is seen in later springs or in summers and fall. Okay, route of entry, how the infection takes place, it usually occurs from the mucosal surfaces of the respiratory and the GI tract, and later there is a viral replication. Okay, and then viremia is seen. Okay, and it is a most common kind of an enterovirus. So clinical features what we see in neonates and infants, as I told, like fever and non-specific, like poor feeding, vomiting, diarrhea. See, these are common symptoms that we see in any of the child or infants when they come to us. The basic history that we take, like is the patient feeding properly? Is there any episodes of vomiting, diarrhea, or any rash or respiratory? So basically, the produce when we proceed for any clinical examination of the baby, we always go with the ABCD, as I told in my sessions. So D, this is the disability, and E is exposure. Exposure, we check for the rash. A is airway, B is breathing, C is circulation. Okay. So CNS manifestations that usually we see in such patients is irritability, lethargy, usual rigidity, or bulging fontanelle. Okay, you should know this. Basically, practically you should know how to check for the fontanelle. Encephalitis, seizures, and focal mites. And in older children, we see fever, headache, vomiting, stiff neck, and photophobia. Okay, stiff neck, we need to do examination. You know, the signs. If anyone can tell me what kind of signs we check for stiff neck sign? What is that sign we call? We call it. Anyone? What sign we check to rule out it is a stiff neck for a patient, especially suffering from meningitis? Yeah, turning or any other? The second sign we do. The two specific signs for meningitis. Yes, good. So these two signs are the basic, what we call the most identifiable signs that we do for meningitis, and you should always keep in mind whenever you are examining a patient who has come up with such symptoms, you need to check for all these things. So physical findings, as I told, usual rigidity, bulging fontanelle, particular viruses, example, rash, conjunctivitis, pharyngitis, and diarrhea. Okay. In older children, positive meningeal signs. See, always remember clinical features cannot reliably differentiate viral from bacterial. Okay. And CSF profiles may overlap during early bred bacterial meningitis. So it is like this has to be proceeded in a good way. We need to be very clear diagnostic and need to do proper scans, proper tests for that. So, can anyone tell me like what can be a differential diagnosis to this meningitis kind of infection? As I told, patient coming up with fever, vomiting, refusal of feeds, seizure history, cold calamities, and what can tell me? Anyone tell me like what are the different differential diagnosis we can go for meningitis kind of an infection? Any two or three names? Yeah, tuberculosis. Yeah, we can find. Other than meningitis, I'm asking. Any other disease that comes to your mind, which a person can be. See, he's having a headache. He's having fever. He's having malaise. Yes, good. Very nice. Subarachnoid hemorrhages. Yes. Any other? Come on. Hemorrhage can be one thing. Encephalitis is also good. Any other? So, can be brain abscess. Yes. A brain abscess can be also represented with such symptoms, or there can be any kind of a tumor, we can say. Okay. Or it can be a bacterial endocarditis, or it can be a septic embolism also. Okay. So, how do you define viral meningitis? It is non-polio EV serotype Coxsackie AB ecovirus made on human only, fecal-oral route. The incubation period is 3 to 6 days. It can manifest like as conjunctivitis, pharyngitis, rash, herphangia, hand, foot, and mouth disease, especially in infants. Okay, and diagnostic is only, as I told, CSF PCR and humoral immunodeficiency, especially X-linked gamma-globulin are the risk for chronic EB meningoencephalitis. This you can only remember as a part of your exam, but the main thing that you need to know is what is the route of transmission, what are the manifestations that we see, symptoms, and the diagnosis for them. So, while HSV more of the meningoencephalitic picture, and it can be neonatal and post-neonatal type HSV 1 and 2. Incubation period is 4 days. As I told, CSF and PCR is the diagnostic. The non-infectious causes for aseptic can be drugs, especially ibuprofen, azathioprine, and IV. So we always should properly maintain the doses, and we should know which thing needs to be given. See, you need to remember ibuprofen and azathioprine because many cases been reported into such things, and the malignancies, especially in lymphoma and leukemia, and autoimmune, it can be sarcoid, Burhett's disease. This you can remember, and other causes it can be epidermolysis, intracranial hemorrhages. So, what do you can tell me? Like, what is the most common pathogen we can tell which causes such kind of meningitis disease? Can anyone tell me? Most common causing pathogens causing meningitis. Due to which? Staph aureus, yes, good. You can say Staph aureus or any other pneumococcus. Very nice. Streptococcus meningitis, Neisseria meningitis, nice. One is missing, the major one. That is the most common one we know. The most common one we remember. We should always remember when we are discussing. Yes, very nice. Someone saying. Yes, tubercular, Mycobacterium tuberculosis is also the most common one. We should always remember. Any other? Any influenza? Any influenza virus, if you remember? Hemophilus influenza. Okay. So, now I want to know what examination findings or an observation would you like to immediately in such cases? Like what kind of examinations and what kind of findings and what kind of observations you need to check for such patient immediately? So what all you're gonna see for such patients? We sensorium good. Focus. Yes, we need to check a focus. We need to check sensorium. Patients come if in aggravated diseases, patients usually come with altered sensorium. Very nice. The primary is a sensorium. Yes. Other any other thing? What all we need to check for such patients? Yeah, signs fine. Very nice. Signs that we go later, but neck rigidity. Okay, good. Do we check for any kind of a respiratory infections? If any patient, any do respiratory examination for the patient, yes or no? Yes. Okay. And any bone, you need to check for knee jerks, yes or no? Do knee jerk for the patient, bone examination, check any kind of an arthritis kind of a thing. Yeah. So always remember, we need to go always step by step. Diagnostic, you can make a very good diagnosis only if you proceed a patient with a proper evaluation from head to toe. Okay. So first of all, we said need to check with the sensorium. Very good. Okay, we check for neck rigidity signs. Very good. We go for it. We check for any kind of a respiratory A, B, C, D, E. Always proceed A, B, C, D, E. We check for any respiratory examination. We check for knee jerks. Any other. So always remember, always keep differential diagnosis also in your mind. So in per abdomen, what we need to check?